What if you could add six-figure revenue stream to your practice? How? Just by doing a better job staying in touch with your patients between visits. And what if the data system from the same system helped you negotiate even better payments with your payees? I'm talking about remote therapeutic monitoring, or RTM, and you may think that you know all about it, but how about if you find out the real truths behind it? That's what we're going to get into today with Steven Coen from SaRA Health. So stay tuned. I'll see you in a moment. Welcome to Your Practice, Your Money, where clinical success meets financial freedom. I'm your host, Dr. Dimitrios Kostopoulos. Today, we're talking about one of the biggest underused opportunities in outpatient rehab. And this is remote therapeutic monitoring. As I said before, you may think that you know all about it, but there is probably lots that you don't know about it and misinformation that you may have. So, done right, this RTM helps you stay connected with your patients in between sessions, improve adherence and outcomes, and also generate real, legitimate, and compliant revenue for the work that you are already trying to do. So, to help unpack all this, I have with me today a very good friend, Steven Coen. Steven is the co-founder and CEO of SaRA Health. And I'll tell you a little bit more about that. But I also know Steven because he serves as the administrator of the private practice network IPA we have in New York. And it's been a real pleasure working with him because we are working to strengthen the voice and negotiating power of independent physical therapy practices in New York. And hopefully we can help you guys as we become successful in your state too. SaRA Health is a leading digital health platform that helps physical therapists and musculoskeletal providers to extend care beyond the regular PT visits that you see your patients. So in between those visits, Steven's work really sits in the integration, I would say, of policy, practice, and innovative technology, which is exactly what we need in today's environment. And before I jump in to ask Steven questions, which you know that I never share the questions with my guests, please remember to click follow right now and subscribe to Your Practice, Your Money on Spotify, Apple Podcasts, and or wherever you listen. And if you find value in these conversations, please leave a review, a rating, and help more other private practice owners to discover the show. So, all right. Welcome to Your Practice, Your Money, Steve. Thank you for joining me.
Thank you so much for having me and giving me some time to chat.
So the question really I want to ask, what is the primary value of RTM from both a clinical outcome point of view, patient engagement, and also new revenue? Or it's combination of all three?
It should be all three, right? As we think about it, for it to really work, you have to have all four stakeholders of healthcare to be happy, right? So you have to have the patient seeing value, the provider seeing value, the practice seeing value, and even the payer seeing value, right? Now, the payer piece is already kind of taken care of because they have put the CPT codes out there. they're expecting them to be utilized, right? So you kind of got that one at least a little bit checked for now, and more research, which we're going to start leading the way on as we look at our 2026 plan to make sure they stay around and continue to flourish. For the patient, we've done some internal research ourselves. We do see things like better adherence to home programs, better adherence to plan of care. So in 480 patient analysis, we found that patients on SaRA had a between 19 and 62% increase in completion of plan of care, right? So they're not giving up. They're not getting to visit number two, be like, I'm sore, this isn't working, and I'm out. This is just not happening as much. And so you have the clinical outcome, right? But we've also seen patient satisfaction increase. And the way that it works is kind of like this flywheel. The patient engages and gives some level of data to the provider. Now, the provider has that and can now have a more efficient and meaningful visit, but especially the subjective. Like your subjective should be done by the time the patient walks in the door, right? And so you're not asking, hey, Demi, how's it been going since we last saw each other? It's, hey, Demi, I see that your pain has gone down. You've been good with your home program, but the stairs are still giving you trouble, right? Like, and that's the first statement. Like, that's where you start. And so now as a clinician, I know what's going on in between visits, and my patient is being more adherent. And then the practice generates high margin revenue. If you generate an extra $200 a patient, but you're only keeping 5% of that, like it matters, but it doesn't. Now, if you're generating 100 and you're keeping 70% of that, that starts to really matter because if you're on average netting about, let's just say $150, right, in an episode, and you're netting $150 on your normal, your visit codes. If you add $70 to that, going from 150 to 220 is almost a 50% increase in bottom, like that's bottom line. So that's how we see it. Patients get clinical value as well as the connection, that safety blanket almost that has been ripped out of healthcare in many ways. The clinician gets more data to be able to have more effective visits, as well as a little bit of that same connection, right? One of our PTs that uses SaRA, she said it really well, is like, it is helping repair the moral injury of not knowing how Mr. Jones is doing the next day. Because now I can without having to put any additional effort into it. And then as a practice, if you can start generating an extra $70 in margin per episode, that is for many extremely meaningful.
Are there misconceptions from clinic owners about RTM that while it makes sense, it just keeps them from getting started?
There are both misconceptions and real roadblocks. So I think there are both, right? There are some things that are very real objections. I think some of the misconceptions are that I have to dedicate some like umpteenth amount of time to this, right? It really should fit in your workflow. And SaRA, like I'm biased, right? But we're not the best platform for everybody. And so finding the platform that best fits into your culture and workflow can help with some of those misconceptions. And I think one big one that I hear a lot is, oh, it has to be home exercises. Like that's the only thing that payers are paying for. And no, that itself is a misconception. The rule is that you have to use a software as a medical device to monitor the patient. And so as long as it's software as a medical device, you're golden. And we took a different route because we've been at this for almost 10 years now and have learned a lot. And our software as a medical device is based on our algorithm that chooses the questions that go to patients. So it's a different approach. Again, is it best for everybody? No, but it's a different approach. So that's one big misconception that, or two, that it's going to take a ton of time. It shouldn't, right? It really shouldn't, but it can, but you'll get paid for it in those situations. And that it has to be an app, it has to be home exercise, and that's not true either.
Some therapists at some point said, okay, you get a ton of audits if you implement RTM. Is there any evidence to that?
I would say no evidence to that. We've probably delivered millions of dollars in reimbursement to practices, and we've had one code get picked. And so far, as we've been able to see, there were no questions back after we gave the documentation. As we look at 2026, it's good for folks to be thinking about not just going after the device or technology codes or just the time-based codes, right? And to really think about how you can intersperse both. And of course, we help groups with that. And CMS even clarified in the 2026 fee schedule that you can count the time in person with the patient discussing RTM data as time towards those time-based codes and asynchronous interactions. So CMS came out like, look, for PT, especially you guys are seeing these patients a lot. We understand if you're seeing them 3 times a week, a phone call on Tuesday and Thursday just it could feel very forced versus it's very much within the letter and spirit to be able to say, hey, thanks so much for responding these last couple of days. There's this thing that you said I really want to talk about. And the patient's on the bike, you're not billing any other codes. You have a 5 minute conversation, boom, like it's right there. We have not seen a ton of audits. Is it possible you could get one? Absolutely, as we've seen. But I think that goes back to are you using a software as a medical device? If so, that's a big piece of it, and especially if they have a letter like us from the FDA, like here, that's part of our response back. But I think as we look at 2026, the more you can even out the usage of the technology and the time-based codes, I think is going to just further de-risk the likelihood of an audit as well as de-risk the potential of the audit going the way you don't want to.
Talking about the time that it takes to participate in the program, right? Let's say I'm going to take a physical therapist who does not have the easiest schedule. I'm not going to take those practices that see one patient per hour, okay? Because that is a rare find and it will be becoming more and more rare. I'm going to take a practice who, let's say, they see a patient every half hour, like
Mhm.
2 patients an hour, and in between a couple of new patients. So let's say they're going to see 12 patients in total. Some are new, some are regular follow-ups. So how that will work throughout their day, what they will have to do, and how they're going to do the processes required to assign and follow up their RTM patients.
Two lenses I want to take to that. So one is in a clinic like that, we're probably having a discussion around do you want this to be purely clinician owned, or do you want to have what we call mission control, which is a person or multiple, depending upon your volume, that is some level of dedicated to being first line of defense, is how we think about it, right? And in that level of volume, we're probably looking at a mission control setup to be that first line of defense once the patient is enrolled. In our opinion, patients should not be like enrolled into the system by a clinician. There is no clinical value in that data entry. And so have your front desk, whether virtual or in person, do that. Our most successful groups have that with occasionally a tech, if you have a tech in your office doing the enrollment.
I'm going to throw out some names and just tell me if you guys are integrated. Athelas,
Yep,
Prompt,
yep,
WebPT,
yep,
Clinician,
yep,
Raintree.
yep. Some of the others, Stride, Therapy Source.
Good. With the first five or six, we have covered probably 95% of the PT industry. Okay. Does this mean less manual admin work from the person who will be entering the data for the patient?
Yes, as the front desk is entering in the patient into the EMR, they're in their chart, right? Or their, the patient profile. Our Chrome extension is going to read that and be able to say, oh, Miss Smith isn't in SaRA. And then our Chrome extension changes to have a plus button. You hit that plus button, we pull all the info that is in the EMR and have it auto filled. And so that way, boom, quick check, submit and that's it. So slightly different on Raintree because we have actual like API access. So it's slightly different, but same principle for Raintree. In as little as like 2 clicks in a Sandy check on the front desk or an admin side, patients enrolled. And then when you're as a clinician, when you're in that chart, and even the one that's moving through at a high volume day, they'll be able to see our Chrome extension will change when they're in that patient's chart. They'll be able to see if there's unread messages from that patient. Click, boom, and then on the side it opens up straight to that patient, straight to their data responses, and then open up the chart. Again, getting warmed up on the bike. Boom, click that. We're logging that time automatically as well that you're spent reviewing, and you have the data, right? So it's not like you have to go to 27 different places. It's all at your fingertips. Then you just use the data, right? And again, it's replacing the how's it been going since we last saw each other question.
In their day, what are specific functions that the physical therapist will have to do? Okay, we got the administrator, we got the front desk person or an admin designated person. What is the function of the physical therapist and how long that therapist will have to spend?
Ideally, it's part of the visit, right? They're just using the data as a part of their follow-up visits with their patients. That works really well and is sort of our minimum standard. With a cancellation, reschedule, or anything there, we would like for them to be reviewing their unread messages and potentially responding back to patients. It's purposely built to get through as many patients as possible. And it doesn't have to be novels. It's part of our training. So what we've realized is if patients simply get two custom messages from you, question goes out, did you do all, part, or none of your home program today? Reply all, part, or none. Patient says all. You see that, like, awesome. And that's it. It is one word, maybe with an exclamation point, and that's it. We find if a patient gets two of those over their episode, they are 80% more likely to rate the experience a 9 or 10 on the Net Promoter Scale. Highly impactful. These low effort, high impact things that we've learned over the last few years is part of our just training process and also sharing with the entire group because I would imagine that some of those best practices survive into other platforms as well, right? Patients just don't want to know it's not going to the abyss. That's really it.
The therapist interaction, let's say a patient comes for PT only once a week and the patient does not come, let's say, skips a week completely. Can the therapist call the patient or text the patient and still that can count as an interaction?
Yes, that's where we log that within our system, depend upon what code it counts towards. Snow days, right? Those types of cancellation days, that's perfect, right? Just get in there, respond to some patients, especially if you see anything that's a little bit more alarming, like give them a call, right? Or, Miss Smith couldn't show up. Let me call her during this cancellation. Not only are you delivering care in a time where no care would have been delivered, but also you're going to get paid for what typically would have just been a complete burnt period of time.
Tell us a little bit about the billing structure of RTM. How does that work?
You asked about misconceptions and real objections. The billing part, there's again both there. So I think a big misconception is that only Medicare pays for these codes. That could not be further from the truth. So what we've seen is that many commercials do pay. So United, Humana, Aetna, reliably across the nation. Medicare replacement plans are like 90 to 95% of those pay. Even Cigna, who has a negative coverage decision about RTM, their HealthSpring plan pays for RTM because their Part C plans need to follow the Part B fee schedule. And so a lot. And then when it comes to the Blues, depends on your state, right? Blue Cross Blue Shield of Tennessee does, Florida doesn't. I would say yet. We've seen Blues continually, like Blue Cross Blue Shield of Kansas started covering in February. We've heard Care First started covering in July of this year, right? Like it just keeps ticking down. Work comp, it's going to be state dependent, but that can be an extremely good payer for RTM. And we've seen some groups that they get their best payment from either the TPAs or the work comp insurers like Travelers. So the VA pays, TriWest pays. I think TRICARE probably will now that Humana is starting to administrate that plan. The whole idea of that only Medicare pays for this is that is a misconception. That this counts as a visit is also a misconception. So there's very distinct language that this is sometimes therapy, but should not count towards the visit allotment. Now, the real pieces are your billing team probably hasn't seen these before, right? So there is education there. We do help with that of like, hey, here's the denials you need to fight. There is some real training that needs to occur there. It's also why we launched in-house billing. So we now have an in-house billing team that only bills the RTM codes to help take that off practices. Your EMR may or may not be able to handle it very well. So certain EMRs don't handle it well if you try to build RTM codes outside of a visit. They'll like attach a copay, or in their system, it'll count as a visit, even though the payer isn't counting it as a visit. So like those are some very real workflow issues that again, why we just brought it in-house. But I think that's a good if anyone is going through the process of EMR shopping, is asking that question of like, how do you bill RTM within your EMR? How does it actually work? If your sales rep starts with well, that's that's probably not great.
That's a sign.
Not a good sign. So, and again, that's why we brought it in-house. So clinicians can actually just click sign note within SaRA. It pushes to us. We submit the claim, fight the denial. It goes through your own clearinghouse and all that. So you get paid just like any other code. Just like a hospital has, 8 different billing companies or units, because anesthesia billing is so different than PCP is so different than ortho, than OB, etc. We brought it in-house because it's just so different than your typical visit or treatment codes.
Steve, how about the actual revenue that can be generated? And based on your experience, what is the profit margin on that revenue?
That is going to be highly dependent on vendor. First of all, each group has their different approaches to it. Typically, what we're seeing from a margin standpoint is the practice keeps about 70 to 80% of the revenue, and we get about 20 to 30%. Like, generally speaking, that's about how it shakes out. And as far as how much, right now, on average, I think our average patient is generating about like $55 in reimbursement for a practice. In 2026, based on the new codes. That looks to a little over double. In particular, is one new code called 98985. 98985 pays if a patient engages between 2 to 15 days of data exchange. That is a massive, massive shift. And a day of data exchange is if a patient, in our case, replies to the question. So if they reply to the question that day, check, that is a day of data exchange. In 2025, a patient has to respond 16 to 30 unique days in a 30-day period for you to be able to generate the CPT code 98977. As you can imagine, although we see it happen every day, it's pretty darn difficult. In 2026 and beyond, there's a new code. So this is, call it 77. There's a new code 98985 that fills in this gap to where you can start getting paid for 98985 if the patient responds between 2 and 15 days of data exchange. And most of our groups are going to see a minimum of a doubling of the RTM codes that they will generate as a result of this new code. So massive. Some groups are going to see like 6 to 7x increase because they have so many people hanging out in like the 7, 8, and 9 response range. And the beauty of it is this code and this code, same amount.
Wow. So whether the patient has 2 to 15 interactions or 16 to 30 interactions, the amount of money for the code is the same.
Exact same.
That's crazy. Wow.
Yeah.
Interesting and good.
Yes, of course. I run a business that benefits from more RTM codes getting generated, right? Like, I'm not going to try to even hide that. But I'm also really excited about the amount of innovation that I'm already seeing as a result of this new code. So, for example, we serve some groups that are primarily in the assisted living and independent living space. And one of the things that they've really struggled with is how to really involve and benefit the caregiver or power of attorney, right? And at 16 to 30, you're adding to caregiver burnout, right? Like, you're not helping with it, you're adding to it. But at 2 to 15, now these groups are figuring out ways like, oh, well, now we can get the POA involved, get really good data on how mom or dad is doing, and be able to incentivize the investment and delivery of more caregiver resources through this code set. Is it a little bit of an adaptation, right? Like, you're meeting the thresholds, absolutely, and then doing something more with it? Yes, but that's the beauty of it. I think that's why CMS kept it vague of it's the monitoring of the musculoskeletal system. That is extremely vague. Even for like speech SLPs, speech paths, like swallowing is a retraining of the musculature, right? That's the musculoskeletal system. And you wouldn't have maybe thought that coming into it because of the amount of leeway that CMS gave to just see what happens. We're seeing just really cool, innovative practices and innovative ideas that folks are helping us build a better platform to be able to serve.
many of you who are also involved in diagnostic testing like EMG, nerve conduction, MSK ultrasound in your practice or in your satellite locations, if you are interested in incorporating alongside your diagnostic testing RTM, just text me, call me, email to me, and I will spend some time to discuss it with you, and I'll refer you over to Steven so he can sign you up on that and how specifically you can do it. But tell me something. What sets apart from other RTM companies?
Today, two things. Starting 2026 will be three. Our software as a medical device distinction being our algorithm allows us to deliver the patient experience in purely SMS text messages. There's no app to download, there's no website to go to, and we're also not tied to a home program. You mentioned diagnostics, right? And we've learned this, especially early on with manual therapy in particular. There's not always a home program right off the bat, or potentially ever, right? Depend upon exactly what you're in the vestibular world, the vertigo world, right? It's like it's ADLs, it's just different. Our flexibility allows you to get the data you need and not try to force fit it into some sort of app or web application. And also our enrollment rate is really high as a result, right? Like, hey, Demi at SaRA PT, it's standard of care for us to check in on you and give you a way to communicate with your PT in between visits. We're going to enroll you. You can always opt out. The second would be in-house billing, taking over the billing so that way your team doesn't have to figure it out. And then we've launched this with a couple groups now, but are going to really be hammering it in the future, is an integration and partnership we have with North Coast Medical. So some of you, maybe many of you have heard of North Coast, right? If you've bought dry needles from them or your TheraBands or hip circles, pulleys, etc. We have an integration with them that allows you to set specific patient bundles by what you're treating them for, and we can automate the delivery of that. So a patient can get their hip circle, shoulder pulley, and hot pack that you typically like to give to every total shoulder patient, and we can deliver that link for the patient to buy it, all automated. And then typically the patient gets it for as much or cheaper than what they can buy on Amazon, and it's not counterfeit, which is so you don't have to worry about it breaking, like some other things that patients might find. And there's also a benefit to the practice in that we'll just say it pays better than the Amazon affiliate link. Patients like it. Like, I don't want to have to figure out what to buy. Like, just tell me. Those are the three things that really set us apart.
I would add to that the awesome customer service and helping, standing by the side of the practice owner.
Our
Yeah.
business model is we only charge you for paid CPT codes. I care a heck of a lot if your team isn't billing the codes, if your team isn't fighting denials. Our business cannot exist unless you are actually benefiting financially. To your point on customer service, it is ingrained in the business model to have that be number one.
Stephen, where are we heading in general in the PT profession, especially that in private practice? There's a lot of consolidation. There is struggle with reimbursement. Where are we heading? What's happening out there? What's your take?
The general demeanor at PPS this year versus last year was markedly more positive. I think there's a general larger sense of hope. You know, new codes like this that are going to be helpful. You have CMS pushing out new models, like the Access model, which just came out, now. And do we know exactly how PT is going to fit into that? I don't know exactly how yet, but if that's the way that we're going, right, is like finding ways to bonus based on outcomes, right? Kind of like MIPS. You're seeing more and more of these models, and I think that's good for PT as one of the most conservative, high value, high ROI treatment options for musculoskeletal and beyond, right? We're not even talking about traumatic brain injury, vertigo, vestibular, those other disorders that can plague people that PT is in particularly positioned to do well on. I think the industry has done the right things for a long time, and at some point, I just won't believe otherwise that there won't be reward. The value exhaust that is today, there's no CPT code for a avoided total knee replacement, right? Like I love that, and there isn't today, and there may never be that CPT code, but I think the models that are being experimented with are going to get close. So I think there's a lot of reason to be optimistic, but there's also very real headwinds facing the industry. And I think what we're doing at PPN, right, at the Private Practice Network, and finding ways through a lot of blood, sweat, and tears by you and the rest of the board to change the dynamic. And people are more willing to take risks. I don't think it's necessarily like highly risky, but just more willing to say, you know what, our bigger enemy is the enemy to the profession, not the competitor across the street.
Absolutely. Look, there are plenty of patients that can be serviced by physical therapists. We are 15,000 PTs short every year. And now with the new H-1B regulations, that shortage will be even getting bigger. So if we promote try PT first as the key message, there is so much business that we won't have to really search for it. It will be knocking on our door. So if you are right now in New York, if you are listening, especially from New York State, it's a no-brainer for you to join the Private Practice Network IPA, PPN IPA. And Steven, how can they find out more information if they want to join?
Go to the website, privatepracticenetwork.org. Also, please feel free to email myself, Steven, with a V, at privatepracticenetwork.org. We're not just negotiating just payer contracts, right? It's beyond payer, just purely the payers you think about, like United and others. Now, we are targeting those, and we're seeing some really good success, especially recently. Also, the discounts that you can get on key things like SaRA, as a friend of PPN, malpractice, cyber, and other discounts that the other board members have been able to negotiate. You would have to try to not make your money back at a minimum. And that's before we even get a contract in your hand. And then beyond that, just the community. For those of you who can't afford to make it to a PPS, we're going to give you that over the course of a year. The discounts, the contracts, and the community, I think it's a no-brainer. And there is an intrinsic value for you to be able to say, I was a part of one of the first.
Awesome, my friend. Thank you so much for sharing your expertise and also for the work that you are doing to help independent physical therapy practices not just survive, but truly thrive. To all of you who are listening, if you are curious about RTM, send an email to Steven. We're going to put all of his information on our website. And if you got some value from this conversation, please follow and subscribe to Your Practice, Your Money, Spotify, Apple Podcasts, or wherever you listen, and leave us a rating and review. When you leave a rating, the highest rating, and you write the best review, it helps more private practice owners discover the show and build stronger and more resilient practices. All right. So I'm Dr. Dimitrios Kostopoulos. See you next week. And until then, keep building clinical success and financial freedom. Take care, everyone.